Welcome back, everyone. Today on Health Code Blueprint, we're diving into mastering documentation clarity, a provider's guide to the Excludes1 note, a guide to accuracy, compliance, and risk mitigation. Before we begin, here's a quick disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Let's get started by walking through the roadmap for today's session. This presentation includes examples of common diagnoses that are often documented together but fall under the Excludes1 rule. This is not an exhaustive list. The goal is simply to highlight frequent scenarios that create confusion and impact coding accuracy. We've all seen it happen. A claim gets delayed or denied, and the clinical care wasn't the issue, the documentation was. One of the biggest contributors to these avoidable problems is misunderstanding the Excludes1 note. So, let's break down what Excludes1 really means and why it matters. An Excludes1 note means two conditions cannot be coded together for the same encounter. It's not optional. It's not a use with caution. It's a mutually exclusive rule that requires you to choose the single code that best represents the patient's true clinical state. Now that we've defined the rule, let's look at a simple mental model to help you apply it consistently. Instead of memorizing dozens of combinations, we're going to simplify Excludes1 by organizing it into three core principles. First, specificity and causality. Second, hierarchy of severity. Third, distinct clinical states. These three concepts will guide every example we walk through in this presentation. Let's start with the first one. And as we move through each scenario, always remember to check the index and tabular list to confirm whether an Excludes1 note applies. This principle is all about coding the why. When one diagnosis explains the cause of another, you code the underlying disease, not just the general manifestation. Let's look at a few examples to make this clear. When peripheral vascular disease, PVD, is caused by atherosclerosis, you don't code both. PVD is a circulatory condition where narrowed vessels, often due to plaque buildup, reduce blood flow to the legs and feet, causing pain, numbness, or tissue damage. In ICD-10-CM, the atherosclerosis code already includes the PVD component, making it the more specific diagnosis. Because of that, the atherosclerosis code replaces the more general PVD code. This same logic applies to our next example. Angina often occurs because of coronary atherosclerotic disease, CAD. So when the provider documents both, you don't code angina separately. The coronary atherosclerotic disease code already covers it. Think of it this way. Same cause, angina and coronary atherosclerotic disease both come from plaque buildup in the coronary arteries. Where the disease is, I-25.1 equals disease in the native coronary arteries. I-25.7 equals disease in bypass grafts or transplanted vessels. Symptom built in. These coronary atherosclerotic disease codes already include with angina pectoris. So, the I-25.1 and I-25.7 subcategory codes give you the full picture, the cause, the location, and the symptom, which means you don't assign a separate I-20 angina code. One more example under this principle is epilepsy and convulsions, where the more specific diagnosis, epilepsy, replaces the more general code for unspecified convulsions. If a patient has a confirmed diagnosis of epilepsy, you don't pair it with R56.9 for unspecified convulsions. Epilepsy is the more specific, established diagnosis, so it stands alone. Unspecified convulsions, R56.9, typically describe a single or acute symptomatic seizure when epilepsy has not been diagnosed. Epilepsy, by contrast, is a chronic condition defined by two or more unprovoked or recurrent seizures occurring on separate occasions. Because these represent different clinical states, it's essential to document the type of seizure and the patient's overall condition to ensure accurate, compliant coding. Some diagnoses exist on a spectrum. When that happens, ICD-10 requires you to code the most severe or progressed condition. Let's look at how this plays out. If a patient meets criteria for dependence, you don't code abuse or use. Dependence is the highest severity level, so it replaces the others. Chapter 5 of ICD-10-CM covers substance use disorders, including codes for unspecified psychoactive substance use, abuse, and dependence, all of which must be supported by clear provider documentation. We go deeper into this in our ICD-10-CM video series. A patient with dementia should not be coded with mild neurocognitive disorder. Dementia is the more advanced condition, so it takes precedence. Mild cognitive impairment, MCI, involves noticeable issues with memory, focus, or word finding, but the patient remains independent in daily activities like managing bills or self-care. Dementia, however, represents a more severe decline, one that significantly interferes with daily functioning and independence. Now let's move to the third principle. Some diagnoses represent completely different clinical realities. Excludes1 prevents you from coding two conflicting states at the same time. Here's a perfect example. If a patient has bipolar disorder, you never code major depressive disorder or a depressive episode alongside it. Bipolar disorder already encompasses both manic and depressive phases, so coding a unipolar depressive condition would conflict with the clinical picture. Another example of distinct clinical states is post-stroke coding. A patient with no residual deficits after a stroke is coded with a personal history code. A patient with ongoing deficits is coded with a sequela code. These two states cannot be coded together, they describe completely different clinical realities. A stroke occurs when blood flow to part of the brain is blocked or when a blood vessel ruptures, leading to the death of brain cells. Whether the patient has no deficits or ongoing deficits determines which code category applies. Now that we've covered all three principles, let's bring it together. When in doubt, ask yourself, do my diagnoses tell a single, clear, and specific clinical story? If the answer is yes, you're likely on the right track. Let's close with why this matters. Applying Excludes1 logic doesn't just help coders, it strengthens the entire revenue cycle. Clear, precise documentation leads to fewer denials, faster reimbursement, and more accurate patient data. It ensures the clinical story is complete, consistent, and compliant. And as always, remember that your ICD-10 CM guidelines and coding books serve as the final compass on your coding path. Thank you for joining me for this walkthrough of the Excludes1 note and how it impacts documentation and coding accuracy. I hope this helps you feel more confident navigating these common scenarios. See you in the next video.